Welcome to all those who are signed in for the second half of this webinar. My topic, objective de-resuscitation, is similar to Kathy's, but as you may suspect, it's the opposite. I'll be talking about stroke volume index, cardiac index in patients who have excessive fluid and who need to have lower stroke volumes and lower edema and fluids in their extravascular spaces. I work in a 12-bed ICU where I am an intensivist, pulmonary doc, and internal medicine board certified doc. I am a speaker for Edwards and have created a small software company that does do deeper dives into vital signs. The three things we'll discuss will be going over some definitions of the resuscitation, de-resuscitation, the physiology of the stroke volume index, and it's similar to Kathy's stroke volume. It's just be another indexed variable, and then two case studies at the end. So for the definitions, what is de-resuscitation? I think you already know. I found this fire hose connection on a building, and if any of us give excessive fluids to patients, and excess would be relative, then they may need to have fluid removal, or they may need to have the vasopressors added to support their function. And de-resuscitation would be the removal of this excessive fluid and a decrease of the vasoactive meds that they will no longer need. So if we were to look at that Starling curve, these are patients who are over the curve. They're over the curve, shifted to the right where the curve decreases, and they are working with excessive fluid that you may judge should be relieved. So some of these could be congestive heart failure, renal injury patients, post-operative patients, or post-sepsis patients, all with excess fluid. Well, questions are bound to be in your mind. An SVI could be normal, or an SV could be normal, but patients could still have excess fluid. Think about that. That's a great question. If the stroke volume is normal, patients could still have excessive fluid. And that will take clinical judgment and opportunities to add certain variables together with the SVI. But SVI, cardiac index, stroke volume, and systemic vascular resistance, as Kathy's explained, will go a great way in helping you discern the patient's physiologic state. We often talk about blood pressure being soft. We talk about a chest x-ray being wet, and we talk about physical exam with pitting edema. None of these will be objective enough to give you the complete picture of the patient. As Kathy says, and I couldn't agree more, if you add your hemodynamic variables, you should be able to discern the state of your patients. So the reason that soft BPs don't work is often because we have our patients on pressors. The fact that cardiac index doesn't directly work is often because they're on vasoactive agents. And some patients do shift intravascular to extravascular spaces due to capillary leak syndromes, as you know, and with hypoproteinemia as well. But if you have these patients and work with your stroke volume index, cardiac index, and SVR, you should be able to discern the fluid balance of these patients. So the curve I present is a parabolic curve where to the left, the patients are hypovolemic. To the right, they have fluid excess. And in the middle, it's just right. They are optimum. And you want your patients to be operating at the optimum section of this curve. My section of the talk will start with patients who are fluid excess. and they're overloaded. We will move them down with de-resuscitation toward the optimum. Well, the question will always be, how do I know how much fluid to take off? How do I know I can reduce the pressors to that optimum level? And I'm convinced with the bedside work that we do and our nurses do, we're able to follow the patient's move to a de-resuscitated state by watching the SV and the CI. So looking at the stroke volume as an index, that is dividing it by the body surface area, should give you a SVI that is low, normal, or high. And you can add that into your assessment of the patient. The technology that we're talking about, the platforms that are at the bedside, you've heard the EV1000 or the Hemisphere. These devices take the arterial waveform and convert it and compute it into a stroke volume. After the stroke volume has been computed, of course, it can be an index. And after the index is computed, you can multiply it by heart rate, again, in the platform, and get the cardiac output or get the cardiac index. So with one minimally invasive connection to the patient or a clear site connection to the patient that's non-invasive, you're able to get the SVI and the CI. So this is just reiterating what Kathy has already said. To go over the numbers for SVI, because I've divided by the body surface area, it's basically dividing by 2 for the average body surface area. So a stroke volume index would be 33 at bottom normal and 47 at top normal. Now I'll joke that I have trouble. I'm a white-haired guy, so I have trouble remembering 33 and 47. How about 30 and 50? So our nurses use 30 and 50 with no problem in differentiating. Below 30 is a low SVI and above 50 is a high SVI. And between 30 and 50, we look at the patient and see if everything correlates. We came up with this hypothesis that will the SVI act as a surrogate of the intravascular volume of the patient? So in the left platform here, the EV1000, you have a clear site on the finger or a flow track to connect to the arterial line, or in the Hemisphere, you have a flow track transducer or the new IQ Acumen transducer, which has more technology than a flow track, but still gives you, for this lecture, the SVI and the CI. After you hook up your ART line to either of these platforms, you're able, using the flow track or the IQ Acumen, to bring your data into visualization for the SVI, the CI, and other hemodynamic variables. This slide off the track of the lecture just states, remember, and our nurses did hook up our transducers this way, it's better to flip the transducer and have the stopcock up. If you notice, both stopcocks are down in this photo. I confess, they're not supposed to be down. They're better if they're up in terms of not having a kink in the tubing. The up tube will be the ART line itself and will have the opportunity to stay patent. Well, when you have the platforms operating, the EV1000 to the left or the Hemisphere to the right, we like displays that are CI, SVI, CO, and either SVV or MAP. So we show the EV1000 and the Hemisphere. Just looking at SVI for this talk, and for my section of the talk, the SVI is 56 to the left, and that's abnormally high, above 50. The SVI is 25 to the right, and that would be abnormally low, at less than 30. Okay, with this background now, so you're into SVI, you're into CI, you have Kathy's introduction as well. Let's look at how we use these hemodynamic variables to take care of patients. So my two patients start with a renal patient, an end-stage renal disease patient, and you might assume right away, well, wow, of course that's going to be a de-resuscitation. I see so many patients who have end-stage renal. This one, a 67-year-old, has missed the HD session or sessions, is acutely short of breath from fluid overload, and was admitted to get NIV BiPAP at FiO2 of 1 before the emergency hemodialysis could be started. Now, you got to be thinking, what is he showing us this example for? Of course the patient is wet. Of course the patient's wet. They missed dialysis. I'll bet the SVI will be elevated. Well, you're right. Good. You get it. You're getting the basics of this. The SVI is elevated, but how much fluid should you take off? If you take off too much, the patient will have hypotension. If you don't take off enough, the patient will still be wet. Have you ever thought of using the SVI as a de-resuscitation tool for patients on dialysis? Well, we have, and this is the topic that we presented at FCCM. Our nurses watch while dialysis is taking place to be vigilant so that the SVI doesn't alarm below 30 during ultrafiltration, because that suggests too much fluid is coming off. So let's look at the trends. The trend data for this 67-year-old is shown with CI at the top and SVI at the bottom. Now, what's confusing perhaps is a number 4.8 for CI and a number 57 for SVI. Those numbers, given the screen grab, is where this white line is. It's where this white line is, and the vertical intersection of the white line is at a CI of 4.8 and at an SVI of 57. What I'm interested in showing you is back here. This dip was what? This dip was an SVI of 55 going down to an SVI of 37. And what was going on? You might imagine. What was going on was the hemodialysis. I mean, honestly, is this cool? This is cool, because you can follow your patient's hemodialysis with ultrafiltration and have the nurse work with the dialysis nurse and say, doing good, goal of 2 liters, keep going. The patient's SVI is stabilizing, and when you finish dialysis, the patient will re-equilibrate and come back up. So in this case, the SVI decreased during dialysis and then re-increased as fluid was mobilized from the extracellular area into, and mobilized from that area into the intracellular zone. Okay, notice, however, despite all precautions, the patient became fluid overloaded again about 12 hours later as excessive IV fluids were running, and the SVI, still running continuously, warned that the patient was getting fluid overloaded and would either need a new dialysis session or would need a cutback in the fluids running. So in summary, SVI, looking at it as a de-resuscitation, is very interesting when you're dialyzing patients with an ultrafiltration and allows you to monitor their stability on the ultrafiltration. the de-resuscitation figure again would be moving these patients from fluid overload down to optimum. And you watch how much fluid is not too much by watching the SVI. As a corollary to this, and an extra thought, consider the nephrology team that wants to take 2 liters off a patient with an SVI that's low. We've watched again and again that that can't be done under a normal 4-hour session. For it to be done, if 2 liters are needed off, we find these patients don't do well. They drop their blood pressure. They go to an even lower SVI than 30. And instead, their session has to be converted to a SLED or a CRRT in order to obtain the 2 liters off safely. Okay, the second case. To come up with a COVID case is not difficult. This COVID-19 62-year-old female was already on HOMO2 due to COPD, noted the fevers, the shortness of breath, was SARS-CoV-2 positive by PCR, and was put in isolation in the emergency room and expected to do well without the ICU at first with just a high flow, HF, high flow nasal cannula O2, but the patient did develop more hypotension. IV fluids were given empirically. I loved Kathy's comment of the dartboard. Take your dart, throw it at the board, see what you might hit. Fluids? Yeah. Pressors? Yeah. Inotropes? Yeah. And with 3 liters given, a chest x-ray was done, and now the patient, with no doubt, had diffuse bilateral infiltrates. Now the doubt would be how much of those infiltrates were the 3 liters that leaked into the lung, or how much of those infiltrates were COVID with a capillary leak and fluid entering the lung, or how many of those infiltrates were actually a viral pneumonitis. So the patient was moved to the ICU, did get intubated, had severe hypoxemia plus hypercapnic respiratory failure. Well, the first thing I like to know on this patient, besides their vital signs, is what's their SVI and how is the SVI tracking. If you look at the first hours in the ICU shown on this EV1000, the 4 axes are CI, SVI, CO, and MAP. So we've got a good MAP. We got a good MAP, but the SVI is rising as that fluid is being given, and it's a response to fluid that is fluid responsive. When you see a curve going up like this, as fluid is being administered, SVI is climbing, CI is climbing, the patient likes the fluid. But wait a minute. The MAP was okay. So why was the pre-ICU team pushing fluids? They were pushing fluids, and we noted with more hours in the ICU, the SVI was leveling out now, and the CI was leveling out. So more fluid was not working to get any higher hemodynamic review, and the MAP was still holding. Now, one way we like to look at this that's different than the trend is another display that's on the EV1000 and also on the hemisphere. And that is a green box that is a finger display, meaning you just hit the display for a green box, which we call the goal positioning system, a GPS. It's CI on the vertical axis and SVI on the horizontal axis. You just have to move to the screen from your trend, and you're able to get the screen with no problem. On a hemisphere, same screen, same concept, green box, good CI, good SVI. The lines are 33 and 47 for the vertical lines for SVI. Well, our nurses like this box. They set it up with the top variable. It will turn into the vertical axis. The second variable that you select, the second parameter, will turn into the horizontal axis. So you get your goal position box. If you're a mathematician, you may see how simple this is, since CI equals heart rate times SVI. If your patient moves up and down in that diagonal, they're simply moving up and down with a fixed heart rate. A high heart rate would move them to the right. A low heart rate would move them more clockwise. So this display, our nurses enjoy for its simplicity. It means that when you're to the right, you are at a high SVI, which is different than being to the left, which is a low SVI, and that the high should be wet and the low should be dry. And if you're a football fan, we joke every day in the ICU that the team has kicked wide. Well, wide to the right, too much fluid. Wide to the left, too little fluid. In between 33 and 47, goal, field goal. So for this case that needed de-resuscitation, we start out with the first numbers, which were an SVI of 48. And here's the 48, not yet higher than 47 by much, tickling the right goalpost, warning us we may be getting wet. Be cautious with extra fluid. The second step here was the patient did drop blood pressure, and the SVI went up to 6, as the SVI went up to 64. Well, this was a fluid overload. And here's the GPS, a dot all the way up at 64. Although I didn't mention, these fading dots are the trail. The Edwards platforms will give you a dot that is fading every 72 minutes on this display and show you the background of where you have been. Well, at 64, we're wet, and we've got a mean of 58. So this is either going to be pressors or diuresis patient or pressors. Well, there was vasoactive meds added. There was not diuresis, but the IV fluids were decreased, and the next GPS display was moving down nicely to 54. And after that, as we used diuresis, we were able to wean the vasoactive meds off. The final dot was in the green box. The patient had recovered during a organized, methodical de-resuscitation to bring the patient back to normal. So in this case, the GPS display was very helpful. We especially like it during COVID season because you can view it through the window in an isolation room and get your information that is easily seen below the green box, in the green box, above the green box, and let you tailor your therapy. So a GPS display has been something we like to judge how much fluid needs to come off, but not too much. My final slide is a waterfall. Remember that if you're fluid overloaded, your SVI should be elevated. If it's not capillary leak and if it's not hypoproteinemia, if it is decreased over the waterfall, then you're normal. So stroke volume index proves to be an excellent measure of fluid balance. And if we look at the 3 objectives, we've accomplished all 3. And patients have thanked us directly, and I suspect all of you listening in deserve a thank you for the treatment you're giving to not just COVID patients, but to everyone who's sick. And we've put many of their thank you notes, as I'm sure you have, up on our walls in the ICU. And I thank you for your participation.